Our next presenter is Dr. Christopher McDougall. He received a bachelor's degree in chemistry in 1981 with highest distinction and an MD from Indiana University School of Medicine. He subsequently completed a residency in psychiatry at Yale University School of Medicine and a fellowship in child and adolescent psychiatry at the Yale Child Study Center. After 7 years on the faculty at Yale, Dr. McDougall joined the Indiana University School of Medicine as the Raymond Hook Professor of Psychiatry and Director of the Section of Child and Adolescent Psychiatry. In 2000, he was named the Albert Eugene Stern Professor of Psychiatry and Chairman of the Department of Psychiatry. In 2011, Dr. McDougall became the Director of the Lurie Center for Autism and the Nancy Lurie Marks Professor in the field of autism at Harvard Medical School. Dr. McDougall is an internationally recognized expert in the neurobiology and neuropsychopharmacology of childhood onset neuropsychiatric disorders, including autism spectrum disorder. His research interests also include the etiology and pathophysiology of syndromes associated with intellectual disability. He has been awarded 2 Young Investigator Awards from the National Alliance for Research on Schizophrenia and Depression, research grants from the National Institute of Mental Health for the study of autism spectrum and related disorders, and numerous other awards and distinctions. And we are very grateful that you took the time to do this presentation for us today. So I will hand it over to you.
Okay, thank you very much. I appreciate it. Thanks for the opportunity to speak with your audience today. And HADS is something I'd never heard of until I was asked to give this talk. And so I've tried to educate myself about it, and in particular, some of the behavioral symptoms that can be present and can be interfering at times. So I'll talk about medication approaches that you might consider if those symptoms are present and if they're interfering. Next slide, please. These are companies I have relationships with. The first 4 are companies where I help them design treatment studies of their compounds in autism. And then I receive royalties from a couple of books that we edited from these companies. Next slide. There aren't any medicines, as you would imagine, that are FDA approved for use in HADS. So when I'm discussing the use of these medicines, they're more generally for different diagnostic areas in psychiatry, but not specifically for HADS. Next slide. And these are the things that are important when I see a new patient, a patient that I'm seeing for the first time, and I really don't know anything about them or what their target symptoms might be. When I say target symptoms, I mean certain symptoms or behaviors that are interfering, that I try to categorize, and I'll talk more about this, that might be responsive to treatment with a particular type of medicine. So I try to determine which of the possible symptoms the individual might have. It's always important to do a physical examination and a review of systems. A review of systems is something that a doctor does where he asks the family or patient about different symptoms they might have. And really we go from head to toe. So you might say, you know, does your child have headaches as far as you know? How's their vision? Do they have frequent ear infections? Are they having any dental problems? You know, if their thyroid gland. So you really just go right down the body to try to identify any medical problems they might have. And that's important because sometimes medical problems can cause behavioral problems, and you don't want to assume that the symptom is simply associated with the HADS diagnosis. It could be related to a medical problem they have, and it's presenting like a behavioral or neuropsychiatric symptom. But in that, if it's due to a medical problem, you'd want to address it more directly in that manner. Neuropsychological testing is a term that people use to mean different things. Really, what it means is having an evaluation by a neuropsychologist, and they administer your child tests to try to determine their cognitive strengths and weaknesses. So you're trying to determine the things they are good at and the areas where they have more challenges. And that can be very important for deciding what the best educational placement might be for that individual. And it's important to get a family history of things like depression and anxiety, as those disorders might be inherited, and your child may have psychiatric disorders, if you will, that are inherited from the family rather than just being associated with HADS itself. Next slide. And certainly we don't want to think about the use of medication alone or even first. So there are lots of things that you all are very much aware of that you could pursue that could be helpful for different symptoms. And you most likely want to try these things before you consider a medicine. So behavior therapy at times can be helpful. To try to shape behavior, to try to reduce problem behaviors, reduce tantruming or oppositional behavior, those kinds of things. From what I've learned, speech and language therapy is going to be an important component for many individuals with HADS. Occupational therapy often focuses on sensory problems that might be there, or fine and sometimes gross motor abnormalities. Physical therapy would more likely be focused on gross motor challenges. And then special education services, does your child need to be in a specialized school or classroom where they can receive more focused, individualized attention or not? And as I mentioned earlier, doing a physical and a review of systems to identify any active medical problems that may be driving behavior, but that the actual treatment would be for those medical conditions. And then if these things are all addressed and there are still behavioral symptoms that are interfering, is when you would want to consider the kind of thing that I do. Next slide. So when I think about groups of symptoms that individuals with HADS may have that are weaknesses or challenges for the individual, something that could be interfering, these are the ones that seem to stand out to me. And it's unlikely that each individual will have all of these. They will probably have some of these. You guys could tell me if you think there are others that they might have as well. But I'm going to go through each of these categories and tell you what we might do if we were going to use a medication to try to be helpful in these areas. Next slide. So we'll start with speech and language, and certainly there are different types of non-medication approaches to help with expressive and receptive language. And it sounds like expressive language, problems with expressive language can be a big part of what your children may face. Next slide. I've been doing this for a long time, and there really have never been any medicines that we've been aware of that might help with expressive language. And, I see lots of people with autism, and many people with autism have significant language problems. 25% of people with autism never talk at all their entire lives, and they live as long as you and I. But this medicine, folinic acid, it's called leucovorin. It's available in drugstores. A doctor can write a prescription for it. Is something that's being studied more currently. And, folinic acid is something that's in your body. So it's a natural vitamin, if you will. But in some people, they can have antibodies in their body that block the folate receptor. So the receptor for folate sits between your bloodstream and the brain. And folate is in your blood. And what happens is it binds to the folate receptor, and then it gets flipped into the brain. But if you happen to have these antibodies in your blood, they might block this receptor so that the folate can't bind to it and won't get into your brain. And that can lead to significant developmental disorders and abnormalities. So there's currently been evidence published in this journal, Molecular Psychiatry, here would be a good one to look at. And there's ongoing studies where we give treatment with folinic acid to try to overcome the blocked receptor. There's a secondary receptor that the folinic acid that you give can bind to and get into the brain, even if the primary receptor is blocked by the antibody. And this is an extremely safe approach with essentially no side effects. And if I had a child who had significant expressive language problems, it's something I would consider, because there really isn't a downside. It may not help, but if it's possible that it could help with expressive language to some degree. So for the first time, there's kind of a medical treatment, if you will, for impaired language use. It's something to look into. Next slide. What about insomnia or sleep disturbance? So this is a problem for lots of people in general, and certainly people with developmental disorders. And it sounds like in many people with HADS, they may have trouble falling asleep or staying asleep. And you could say, well, sleep is a minor problem for people, but it really isn't. It can be a major problem, because if the child is not sleeping well, their behavior is going to be affected the next day. If the child isn't sleeping well, the family isn't sleeping well, and the siblings aren't sleeping well, and nobody's feeling very good the next day. So getting a good night's sleep is very important. And I'm going to talk about our approach to the use of medicine for sleep problems when medicine is indicated. Next slide. Before you think about a medicine, you want to think about what is called sleep hygiene, meaning try to go to bed at the same time each night, try not to have the television on or computer games. Try to, get the setting in the bedroom such that it facilitates sleep, not eating too late in the evening, all of those kind of common sense things. But even with that, if sleep is problematic, these are things to consider. The first thing we always recommend is melatonin, and it's the safest thing listed here, and you can buy it over the counter at a store. And it would be the first thing to consider for disturbed sleep. You go to the drugstore and you buy 3 milligram strength tablets or capsules or whatever they might be, and you give 3 milligrams every night for a week. And if that doesn't help, then you give 6 milligrams every night for a week. And if that doesn't help, you give 9 milligrams every night for a week. If that doesn't help, you're done with melatonin. Melatonin is safe. I've had people, I've read things recently where there's concerns about its safety. I've never had a problem giving it to people. Some people say things like it only helps you to fall asleep. It doesn't help you to stay asleep. Well, that's not true. Don't listen to things other people say. Try it and see what you observe. But that would be the first thing. Clonidine is a medicine you could try. Clonidine is an old medicine that was used to treat high blood pressure. And the reason it's used for sleep is because it's sedating. And the problem with clonidine, in my experience, is it can often begin to work quite well early on, but the individual can develop tolerance to it so that they begin waking up in the middle of the night. And then that sort of defeats the purpose, and a parent might be giving up to give a second dose. So I generally don't go with clonidine. Trazodone is an old antidepressant that is sedating, and it's really the medicine I rely on the most because I find it to be consistently effective, not always. And with this medicine, I would begin at a dosage of 12.5 or 25 milligrams a day. And I might go with that dose for a week and then increase it by that amount every week or so. And most people will get better if they're going to at a dosage between 25 and say 100 milligrams at bedtime. Mirtazapine is also an old antidepressant called Remeron. And the reason we use it for sleep is it's also sedating. And it comes in a 7.5 milligram tablet. The maximum daily dose is 45 milligrams. We start at a dosage of 3.75 milligrams at bedtime for sleep and go up by that amount every week until the individual's better. And it can also help with anxiety. So if the person has anxiety, which I'm going to talk more about, and problems with sleep, it might be a good choice. Next slide. What about ADHD? So here we're talking about an individual that has problems focusing or with distractibility, and also has problems with motor hyperactivity or impulsivity. And some of you might say, well, what about ADD? There's no longer anything called ADD. It's called ADHD, and it would be ADHD inattentive type if there isn't hyperactivity, or ADHD combined type if there's inattention and hyperactivity. Inattention with ADHD, inattention alone is more common in females, whereas combined ADHD is more common in males. And I learned that this can be an area of interference for people with HADs, probably more likely when they're children. Next slide. So the standard treatment with a medicine for ADHD is a category of medicines called stimulants or psychostimulants. And there are two basic categories of stimulants. One is methylphenidate. Methylphenidate is the generic name for Ritalin. And the other category is amphetamine. And amphetamine, the trade name for some amphetamine compounds would be Adderall or Vyvanse, you may have heard of. Either category can be effective. One may work and the other may not for a particular individual. The good thing about stimulants is when you give it to the individual, you're going to be able to determine if it works pretty quickly within a couple of days. And it's either going to help, meaning the person would be less hyperactive and less inattentive, or it's going to potentially make them more hyperactive or irritable. But you're going to find out after a few days and then be able to move on. If you give the starting dose and nothing happens, then you keep increasing the dose until you see improvement or worsening. But again, every medicine I talk about, you always want to find out what the lowest possible dose is and begin at that dose. So for methylphenidate or a Ritalin-like drug, that would be 2.5 milligrams a day to start with. And with an amphetamine like Vyvanse, it would be 10 milligrams. So these work quickly. Now they're stimulants. So the side effects are going to be, they can cause some stimulation, and that might mean that if you gave them late in the day, it might make sleep worse. So you don't do that. These are usually given in the morning so that you're giving it at a time that's removed from sleep, so it won't cause a sleep problem. You know, in the old days, people might take stimulants to reduce their appetite, sort of like a diet pill. And so they can reduce your appetite. If you had a really thin child, it might not be a great thing to try, but you would do things like, well, make sure they eat breakfast before they take the dose in the morning. So these can be either really, really helpful. In some people, it can make things worse, but when you stop the drug, it gets out of your system quickly. So they're not going to be worse for very long. The other thing is, because they get in and out of your body quickly, you may need to give them twice a day, say in the morning, and sometimes another dose at school around noon or so to get them through the afternoon. The other thing is, because these can also be drugs that people like to use to recreationally, right, to just feel better, they can be abused. So doctors aren't allowed to give refills. We can only give you a 1-month prescription at a time. So you have to get a new prescription every month for that reason. Next slide. If a stimulant doesn't help or causes side effects, or if you don't want to start with a stimulant, you could start with a non-stimulant treatment for ADHD. And one that we use a fair amount of is called guanfacine or 10X. I mentioned clonidine earlier as a sleep agent. Clonidine is more sedating than guanfacine. So we usually use guanfacine for ADHD. And it comes in a 1 milligram tablet. We start with half of a pill or 0.5 milligrams each morning, and we go up as needed. Because these are medicines that can lower the blood pressure, you'd like to have some sense of their blood pressure and heart rate before you begin the medicine, but we use these in low doses, so it's unlikely to affect those measures. These can be sedating again. So if you started a 0.5 milligram in the morning and your child was sleepy, you would want to wait until that wore off, which it will, before considering a dosage increase. And these are usually given in the morning, and then we usually give a dose when they get home from school to help get through the evening. These drugs can also at times cause constipation, so you need to be aware of that. Unlike stimulants, they don't usually make symptoms worse. You may need to give them a couple times a day. There is an extended release form of guanfacine called Intuniv. Now, in extended release means you just give it once in the morning and it lasts all day. The challenge with extended release medicines is that the individual has to swallow the pill or tablet entirely. And many kids have trouble swallowing pills, and you can't break this or cut it up, or the extended release benefit goes away. Next slide. Another non-stimulant or non-Ritalin treatment for ADHD is something called atomoxetine. The brand name is Strattera. And this is a medicine that works by increasing brain norepinephrine. It's FDA approved for the treatment in ADHD in children, adolescents, and adults. And we use it to treat ADHD in people with autism. This isn't one where you take it and you're going to see it affect the person quickly like a stimulant. This is going to be something where you increase the dose over time to a therapeutic dose, sort of like you would with a antidepressant you're taking, right? It may take 4 to 6 weeks to see benefit. The starting dose for us for this medicine would be 10 milligrams in the morning, because that's the lowest possible dose. And we would go up by 10 milligrams every week or so, all given at once in the morning. So this is another alternative to a stimulant for ADHD. Next slide. When I read about HADS, it said that some individuals may have traits or features of autism spectrum disorder, or ASD. So I wanted to tell you the way I think about ASD. Next slide. So autism is characterized by an impairment in social communication and social interaction. I like to think of it as it's an impairment in language and social interaction. So, and it can be a profound impairment in social interaction, such that the individual doesn't have the inborn ability to start a conversation, to look at other people in the eye when they're talking to them, to turn around if someone calls their name. They just may not understand how they're to interact socially. It's not that they don't want to, it's that they don't know how to do it. So they may have to be taught how to interact socially. We take it for granted. Although some of us are shy, we might be able to relate to that. This is more profound social impairment. Now, you may say, I know some people with autism that are very social. You may, but their social interaction may be excessive. They may have trouble with boundaries, so it's still not appropriate, if you will. You know, many people with autism have a significant language delay. They, as I said, they may never speak. They may have good receptive language, so they may understand what you're saying, but they may not be able to talk. It doesn't mean they can't communicate with sign language or by grabbing you and bringing you somewhere, or with some of these speech devices that have been developed. The other thing that's common in autism is repetitive behavior. And I read about HADS, and it said that many of your folks may have this word called stereotypies, which is hard to say and even harder to spell correctly. But a stereotypy is a repetitive behavior that is non-purposeful in a sense. People with autism do it, you know, they flap their hands, they may rock. They're doing that to calm themselves down. They're doing it to feel less anxious. So that's why they're doing it. So you don't necessarily want to eliminate it, because it's something they're using to help regulate their feelings, right? So it may look unusual, but it can be helpful to them. And that's the way I would think about these things if they're occurring in your child. It may be something you don't necessarily want to eliminate. But people with autism do lots of other repetitive things. They might spin things, they might line up their toys. And you could say, oh, you mean OCD. And I would say, no, I don't mean OCD. I mean repetitive behavior of autism. Why do people with autism sit there and spin things? Because they become very good at it. They know what the outcome is. It's a predictable outcome. It's not OCD where they're thinking, oh my gosh, if I don't spin this, my brother's going to get in a car accident. That's OCD. This is rewarding. They enjoy it. It's predictable. People with autism, and maybe some of your folks, do not do well with uncertainty. They need predictability. So don't think about OCD. Don't even mention OCD. It's just the repetitive behavior of the disorder. Now, sometimes people with autism and maybe your disorder become fixated on a topic. They really enjoy dinosaurs. They want to collect every one of them. They become really interested in SpongeBob or a certain toy. Now, that's not OCD. Again, these things are rewarding to them. People with OCD are troubled by having to think about certain things. They don't want to. They try to not think about it. Whereas the things your guys might have are rewarding, and we call them preoccupations. They're not obsessions. So try to get that into your mind, because your doctor might say, oh, you mean OCD. And if the doctor thinks it's OCD, they may prescribe a drug that helps OCD, but doesn't help your child. It may make them worse. So try to really get OCD out of the picture if you can. The other thing we see that's kind of a repetitive deal is sensory sensitivity. So people may have a sensory sensitivity to sound or touch. They either don't want to be touched and hugged, or they seek it out. They want to be held tightly. Or they may have a sense of smell that's extreme, and they may not like things that smell, say, in the kitchen, and you may not be aware of it. They may not want to stay at the table with you. They may be bothered by the sound of people chewing, things like that, that can look like a behavioral problem when in fact they may have a sensory sensitivity. Next slide. Anxiety, my guess is a lot of your folks have anxiety, and they become anxious again when I think things are not predictable. So as soon as people with disabilities walk out their front door for the morning, nothing's predictable. People may come up to them and ask them questions they don't anticipate. They don't know what to say. So it's overwhelming, going to different places they've never been. They like sameness, predictability. Next slide. So these are some of the things that people, at least with autism, do when they're anxious. And everybody with autism is anxious. You may not associate these things with anxiety. You may think, oh, you mean a panic attack. I don't mean a panic attack. I mean doing these things. These things are done when a person is anxious. They may pace. They may run away from a certain area. You call it bolting or darting away. They may bite their fingernails or pick at them. They may pick at things on their skin. That's anxiety. They may ask the same question over and over, even if they know the answer. They know the answer. They're trying to get more information from you. We're going to go to grandma's next Sunday. Are we going to go to grandma's? Yes, I told you that. Are we going to go to grandma's? They know you're going to go. They want you to describe it so they can get a visual image. Yes, your cousin's going to be there. Are we going to go to grandma's? Yes. We're going to take the same car there. Are we going to go to grandma's? Yes, we're going to be there from 2 to 4. So if your child's engaging in repetitive questioning, give them more and more information about the topic, and then they're going to feel a bit better. When they're anxious, these stereotypic behaviors might increase, right? Because they're more anxious, they're doing more of this to feel less anxious, okay? There's a thing in autism called scripting, where these people might have almost like a movie in their head, a Disney movie, and they may be saying what they say in the movie over and over and over. Again, I would look at this as something they're using to calm themselves down. Many times people script when they pace. What about self-talk? Sometimes people with disabilities will say to themselves out loud, even when they're alone, things that their parent might say to them. Megan, you shouldn't do that. Megan, Be a good girl. They may say things like, again, to try to modulate their behavior. Now, if you take your child that's talking to themselves to a doctor or an emergency room, they may say they're talking to other people, they're psychotic. So you want to make sure that you know what it really is, and you explain that to other people. They're not psychotic. Sometimes people that are anxious will avoid others, right? To just reduce stimuli. They may have trouble sleeping because they're worried. They may have temper tantrums because they're trying to communicate to you that they don't feel right. And sometimes they have to have a temper tantrum or a meltdown to communicate that to you, especially if they can't do it verbally. Next slide. What about medicines for anxiety? Now, you guys have heard of SSRIs, selective serotonin reuptake inhibitors, and I'm going to show you a slide of them in a minute, but you've heard of these Prozac, Zoloft, there's a bunch of them. If it was you or me going to the doctor with anxiety, they would probably prescribe an SSRI. But my guess is that in people with HADs with anxiety, SSRIs may make them worse. They may cause them to be more irritable and anxious. So for example, in autism, I almost never prescribe an SSRI for anxiety, whereas in you or me, it would be first line. So you could say, well, then what do you use to treat anxiety in people with disabilities? We use an old drug called Buspar or another old drug called Remeron. Next slide. This is a study of Buspar or buspirone in people with autism who are anxious, and there were 22 subjects, and the doctors were trying to treat anxiety or irritability. Next slide. And the maximum daily dose is actually 60 milligrams a day. And in this study, they started at 5 milligrams 3 times a day. In our practice, we start much lower. This is very important. We start at a dosage of 2.5 milligrams a day, 2.5, which is half of a 5. And that's what you would tell your doctor you want to start on, because they're not going to know. And they're even going to say, Buspar, that's an old drug. And you say, it is. And they say, I want to give you Zoloft or Paxil or Lexapro. And you say, we learned that these SSRIs might make our person worse. So this guy says, use Buspar, and your doctor says, that doesn't work. And you say, it doesn't work for me or you, but it works for people with disabilities. So starting very low and going up by 2.5 milligrams a week, and you're going to give a morning dose and a dose when they get home from school. Very well tolerated, very few side effects. Next slide. The other medicine I talked to you about earlier, mirtazapine or Remeron, an old antidepressant that can help with sleep, can also be helpful for anxiety. And your doctor will say the same thing. Isn't this drug from the 80s? And you go, I guess so. Well, who's this guy McDougall? We want to give you Zoloft or Lexapro. And you say, no, no, no. Those drugs may make my child worse. I want mirtazapine or Remeron starting at a dose of 3.75 milligrams. And your doctor says, that's really low. And you say, that's correct. So if they have anxiety and a sleep disturbance, consider mirtazapine or Remeron. Next slide. So here are the SSRIs I've been talking about. And you've heard of many of these. Some of you are on them. They can be very helpful for depression or anxiety for you, but not necessarily people with developmental disorders. Next slide. Sometimes we find SSRIs helpful in developmental disorders, but if we do, it's more likely to be in an adult. And like I said, these can make you more activated, more irritable. So there really aren't a lot of reasons to think much more about SSRIs, in my opinion. Next slide. What about irritability? you know, irritability is a term that encompasses lots of different things like aggression toward others, self-injury, property destruction, tantruming. That's all irritability. Next slide. Now, this class of drugs called atypical antipsychotics is the most effective for severe irritability. These are not minor medicines. These are major drugs. And they're called antipsychotics because they're used to treat psychosis. It doesn't mean your child's psychotic. It means the drugs work to treat irritability as well as psychosis. And you've heard of some of these medicines. But if you've got severe self-injury or aggression that's not getting better, and it's putting limitations on your family's ability to get out of the house, for your child to go to school, for your child's being aggressive toward a sibling, things that are really problematic, then you want to consider these kind of medicines. Next slide. There are two that you want to think about because they've been well studied in autism. They work, and they're actually approved by the FDA for irritability in kids with autism. And the first is risperidone or Risperdal. Now, drugs that treat powerful symptoms have to be powerful or they wouldn't work. So these things can cause increased appetite, weight gain that can be pretty marked. So you move into this kind of medicine when you have to, and you're glad it's there, but you don't move into it for anxiety or sleep disturbance. Next slide. The other one that's FDA approved for irritability in kids with autism is aripiprazole or Abilify. Let me go back and tell you what I would recommend as the starting dose of risperidone or Risperdal. 0.25 milligrams, very low. And you could go up by that amount every week or two until you see improvement. With Abilify, you don't want to start any higher than 1 or 2 milligrams per day. It comes in a 2 milligram tablet that you can break in half. Your doctor may say, oh, let's give them 5. It comes in a 5. No. 1 or 2 milligrams a day, and you can go up from there. If you give too high a dose, it can make your child feel very restless and irritable and pacing. You can never go wrong by starting too low on a medicine. You can always go up. You don't want to start too high. Next slide. I'm going to skip through the next 3 slides because they're in the same class, but the first 2 are the ones that are FDA approved. Next slide. All right, this is the Lurie Center. What we are is we're a clinic at Mass General, and we're multidisciplinary, meaning we have psychiatry, neurology, gastroenterology, primary care doctors, geneticists, nurses, speech, occupational therapy, physical therapy. We have everything that a person with autism would need, and not just for kids, from birth to death. So we're one of the few places in the world that takes care of adults or people 22 years or older. And, you know, if you're having trouble with behaviors with your child, there aren't people around that are being helpful, we're more than happy to try to be helpful. It's not like we need the business. We have plenty of people to take care of, but I'm happy to help you guys and this organization. And Ashley, if you happen to need extra help or with a complex situation, you can always reach out to me. Next slide. Go to the next slide for a moment. This is my email address. You can email me at any time about anything you'd like, and I'll try to be helpful. I may know somebody that I could recommend where you live, for example, or try to help you more directly. So don't hesitate to email me. That's all I have. Happy to take some questions. Ashley.
Great, thank you so much. Let's see. Does anybody have any questions? We have a few minutes. We can take some questions.
We've got a virtual question. So,
Can you hear?
can you hear Dr. McDougall?
Yeah.
Okay. This is back on folinic acid. Can folinic acid have any purpose for a nonverbal child, or is it just expressive language that it helps with?
You know, it's only been studied so far in kids that have some language, but if I was a parent of a child who was nonverbal and there were no side effects, I would say, why not give it a try? So I've used it in people that have pretty severe expressive language problems to the point of being minimally verbal or nonverbal. And, you know, at times you can see, I think it has the potential to accelerate speech development. It's not going to help you to convert you from nonverbal to verbal, but it could be helpful. And there really isn't a downside to trying it. You would start with, say, 10 milligrams a day, and the maximum dose is 50. Usually it's given twice a day. Something to talk to your doctor about or look into.
I have a question from the audience about, do you have any suggestions about how to get the conversation started with a physician about medicating some of these behaviors?
What I would do is potentially anyway, if you send me an email, I will send you a paper, a review paper that talks about different medicines to consider for different symptoms in autism. And, you know, there's not going to be anything in the literature on HADS, but my guess is that the response to the medicines and the type of things that work are going to be similar as they are in other disorders. And this might be something you could share with your doctor. You know, doctors are not happy about, or they don't have the time to read a long paper, but you might go to a certain section, like say anxiety, and highlight Buspar and say, hey, could you just look at this part right here? And can we give it a try? You know, I'm big on being a team member with the family. Like, let's do this together and make a joint decision. And my hope and my guess is these doctors are going to say, look, you know more about it than I do, mom or dad. I'm happy to help. And if you've learned this from someone that recommends it that we can trust, then I'm happy to work with you. But I'd probably go at it that kind of way.
That's very helpful. Thank you. Are there any other? Can probably take one more question. Okay. You have one? Yeah. Yeah. Go ahead.
Okay, so Dr. McDougall, another virtual question from our virtual audience. My daughter has issues feeding. When she is hungry and avoids eating because of difficulty with chewing. She is therefore very, very small, and we really struggle with her gaining weight. How do we work with stimulants for ADHD, impulsivity, emotional regulation without curbing her appetite even further? She's tried Strattera and guanfacine.
Okay. You know, that's a tricky one. The first thing you want to do is make sure that you've worked on her feeding with a feeding specialist, and you may have. Often feeding specialists will work along with a speech therapist to help with feeding. And again, I may be saying things you know. Sometimes kids with autism that have trouble feeding may have acid reflux. They may have an allergy to certain breast milk or formulas. So you want to make sure all that stuff has been ruled out. But if they have trouble gaining weight, you know, it's gonna be tricky with a stimulant. Now, the thing that comes to mind for me is any of their problem feeding related to sensory sensitivity, right? And if that's the case, you might almost think about it like anxiety, and you might wonder about something like mirtazapine, because mirtazapine can also increase appetite. So mirtazapine at low dose, if they're anxious, if they have sensory sensitivities, if they have a sleep problem, might actually help increase appetite as well as other symptoms.
Well, thank you very much, Dr. McDougall. We really appreciate you taking the time. This is a great presentation.
You're welcome. Good luck. Thanks to everyone. Feel free to email me.
Thank you.
Bye-bye.
Bye.